Thank you. Okay. Good evening, everyone. Welcome to the September WBC Health Overview Scrutiny Committee meeting. Welcome, everybody, and welcome guests. Thank you for joining. Madeline, if I can turn to you. First is apologies. Are there any apologies?
Yes, Councillor Neil and Councillor Eunice and Councillor Shepherd-Bay is online.
Thank you very much. Any questions on the previous minutes of the meeting from July? So do we need to vote on confirming? Can everybody who wants to confirm those meetings, please raise your hand. Thank you. I think that's unanimous. Do we have any declarations of interest? No. Public question time, no questions? Member questions? Oh, Rochelle, you would like to comment?
No, I was agreeing with the minutes, that's all. I'm trying to get rid of this legacy hand.
Thank you, Rochelle. So public question time, member question time, no. So the next section is Hugh, who's going to present the update on the dental situation from, well, in Woking Borough, but a little wider than that with regards to Bob, etc. So I would thank you very much for joining, Hugh, and I will hand over to you.
Thank you. I've just got a few slides to share, not too many, just to support the paper that submitted. So just bear with. Can people see that? Is that gone up on the screen?
Yep, that's fine.
Okay. Yes, thank you for the invitation and the doing the update for the meeting. It was in January, wasn't it? I think we last met. So this is just an update of where we've got to since then. People might remember we talked about access in terms of patients attending over a 2-year period and how that had fallen dramatically during the pandemic. So we can report there's still improvements being seen in terms of the numbers of patients attending dental practices in the area. It's sort of plateauing a bit since early 23, but we are still seeing an increase, and it is about a 20% increase in Bob since early 22, but that's still leaving us some way short of the figures we were achieving pre-pandemic. So whilst it's improving, there's still a long way to go in terms of getting back to that roughly sort of 52% of the population that used to see a dentist every 2 years. The other thing we talked about was how much activity we commission, how many practices we've got. We've got this currency called units of dental activity that we commission from the practices, and you can see this comparison of January and June. We lost a practice at the end of April. The Beanoak Dental Surgery handed back its contract. That was about 10,000 UDAs. That's one of about 15 who've handed their contract back since 2021. We have put in temporary activity to replace that with practices in Woodley and Bracknell sort of covering it. We go out to the practices to seek expressions of interest to do it. So we have got some of that covered in terms of what was lost. And then we're working on a plan now to recommission this activity on a permanent basis from April 2024. And again, that's part of a sort of pan-southeast project to look to replace the activity that's been lost as a result of dentists handing back their contracts. Then the paper also talks about where are we with delivery of activity. Again, substantial improvements in terms of we commission a certain amount of activity from the practices have to deliver a certain percentage of that to retain the funding they're paid each year. That fell dramatically during the pandemic and improved in 21 and 22, and then we ended up exceeding forecast activity by the end of the year. So the overall delivery in Bob was about 80% of contracted activity during the course of the year. Berkshire West and Woking were a bit higher than that, and those figures in Berkshire West and Woking would compare favourably in terms of how other areas did across the South East. So again, a sort of good news in terms of how that's going in terms of the overall position, but again, still some way short of where we were. And I think we were talking at the last meeting about patients who've not been to see the dentist for a while having more need in terms of their treatment, more time than in treatment, and it's taking longer to get through those treatments for those patients. Many access challenges remain, and it's particularly for those who've not attended a local dental practice in the last few years. A lot of the recovery of the access has been about practices recalling patients who previously attended. And so it can be hard for patients who've not attended in a local area or at all in the last few years to get an appointment with dental practices. Often they are more vulnerable groups. We've also talked last time about waiting times following referral in terms of hospital and community-based referral services. And the table, again, which is in the paper, just describes the NHS England contact centre queries and where they're coming from in Woking. About a third of them are coming from the early area. Just then, in terms of what we're doing to try to address this issue. So national contract changes, again, I think we were talking about that in January. They was just sort of being implemented at that time. We've now got all the relevant contract documentation we've got to issue to the practices in terms of the formalities of it. And those changes were really designed to try to improve dentist remuneration in terms of some of the more complex treatments, expand capacity by allowing practices to deliver more contractual activity and provide more information for patients. So that's the sort of features of what was introduced during the course of this year. There are planned further changes to the contract over the next few months as well. So we're waiting to hear more about what that's going to look like. Again, I think we talked about the additional access sessions. This is practices providing more capacity for patients to be seen if they've got urgent treatment needs. The take-up of that in Bob has been quite low, and that is kind of reflective of the fact that practices are having workforce challenges, so it's difficult for them to provide additional sessions. And then also we talked last time about the flexible commissioning scheme that we were planning to launch across the ICB. So that's now happened. That started in June. So we've done 3 months of it now. It's running as a pilot till March 2024. This allows practices to convert some of their contract in terms of the activity targets they have to hit to access sessions. So it takes away that pressure in terms of delivering those targets, and then allows the practices more time for the patients who have got or are likely to have more treatment needs as they present to them. So again, the paper lists the sort of patient groups who are identified. We're looking to support the more vulnerable groups, bringing them into planned care so they have an ongoing relationship with their dental practices. So we went out to the practices. There's about 203 practices in the Bob area to see if they would be interested in taking part in this pilot. So 30 practices have come forward to take part. So we're relatively pleased about that number as for a pilot. So the plan is for about 3,000 of these sessions to be provided over those 10 months. And there's 2 practices in the Woking area taking part, and they will look to provide 148 flexible commissioning sessions. And this is where we are to date. This is the activity to the period between June and August. So across Bob, sort of 643 sessions have been provided, but nearly 2,300 patients seen in those sessions. By and large, it's mainly patients who've not attended for a couple of years or who've relocated to the area. But this scheme is also picking up asylum seekers, looked after children, and families of armed forces personnel. And we've also got this other category where practices can identify patients they think they should bring in. And so we're sort of keeping records of those. And a lot of those are sort of clinical need for those patients to come in and be seen. Wokingham so far, 18 sessions held, 62 patients seen. One of the practices in Wokingham is actually just getting going, really. So they started about a month late, so they've got a bit of catching up to do in terms of what they're doing. Then on the referral services, I think we are making quite good progress on this. There's been sort of investment into these services to try to recover the position in terms of long waiters for treatment. So community dental services, which again is a service for more vulnerable patients, sort of learning disability being a big cohort in terms of who they look after. So the numbers of patients waiting more than 18 weeks 2 years ago was 1,500. That number's been halved by July. The hospital services, this is the Royal Berkshire Hospital, in terms of the tier 3 oral surgeries, it's known, 503 patients waiting more than 18 weeks in April 22. That's down to 42 as at May. And then the slightly less specialist oral surgery, the community-based tier 2 service. Last September, 3,248 patients waiting more than 18 weeks. That's now down to 961. So the providers made very good inroads into bringing those numbers down. So I think in summary, the overall position is improving, but we're still some way short of where we were pre-pandemic. There are still a lot of challenges for people trying to access dental care. We are, testing out a new way of supporting them through flexible commissioning, and we are going to review that and see the extent to which we might be able to continue that and roll that out beyond March. Thank you.
Do you want me to open it up to questions now, Hugh?
Yeah, be great. Thank you. Yeah.
Yep. Tony first.
Hello, Hugh. There's some very good news there. Something that occurs to me, we've obviously got a number of practices who've been voting with their feet and leaving the NHS service. Do we actually approach the dental professionals and ask them what would encourage them to stay, why they're leaving? I know we have been making changes to the contract, but are we doing that interactively with the profession?
We are. So when practices leave, we sort of do exit interviews, if you like, to understand why they're going. We think we have a fairly good understanding of why they're leaving. I can see Nilesh is on the call, and probably helpful for him to come in on this one as well. But we know that the areas that are facing particular challenges around recruitment and retention of the workforce, because that is a big factor here, are sort of rural areas and coastal areas. So that they, as you get further from urban centres, we're losing more practices. So, for instance, in the west of Oxfordshire, we've lost, really quite a bit of capacity out that way. And I think part of the challenge they've got is finding dentists who are, wanting to work in the NHS in those areas. As you get closer to, say, London, if you look in, say, the Frimley area in East Berkshire, and around there, they've lost one dental practice, in the last 2 and a bit years, and that was a workforce issue. They couldn't. They lost 2 dentists and couldn't replace them. So we know that's a big factor, and so nationally they're trying to look at that contract and how they might design that slightly differently. Locally, the flexible commissioning scheme has been designed very much with the dental profession to get something we think that might work for them and for their patients.
Thank you.
Nitesh, do you want to, firstly, a big welcome to you again. Thanks for joining. Do you want to make a comment or question or?
I can do. I mean, to be honest, a lot of what I'll say is similar to what I said in January. Dentists are. I speak as someone who works in general practice, and I was in general practice all today, and majority of my day was seeing NHS patients. So I speak with that background. It's becoming harder and harder to work in the confines of the system as it's currently stands. If I give you some, I spoke before about if a patient comes in, whether they need 3 fillings or 10 fillings, the funding's the same, and so that's some of the difficulties you can all understand. We're obviously working in a high inflation environment at the moment, and if I give you an update to what's happening nationally, whereas we all know in our own houses, in our own backgrounds, inflation's running at 10% plus. The government has just announced that they're going to uplift dental practice expense part of the contract by 3%. So it just gives you a sign of what the profession is facing. And so it's harder and harder to work within the system. And I think all we can do is try and maintain and keep those who are working in there as much as we can. And I'm a great proponent of the flexible commissioning element of the contract that's been introduced, and I helped design that. So that was with the profession. But it's hard. You see in the papers at the moment and all the media about how the doctors are striking. Dentists don't strike; they strike by walking away, and so it's the similar issues that I think that doctors are facing, dentists are facing, and so that's where we are. I'm happy to answer any particular questions.
Thank you, Nitesh. Caroline.
Good evening. It's probably a very simple question. With the vulnerable patients, how are we getting the message across to them about all these services for them? The patients relocating to the areas, looked after children. How are we getting the message across that we have these extra services for them?
We haven't done a sort of big publicity launch, if you like, in terms of that, but we are sort of linking in with health watches in terms of providing them the information about the practices taking part, describing the scheme. The practices themselves are developing some links with agencies that might support asylum seekers. So part of the challenge with bringing in the flexible commissioning is trying to get a service that meets the needs of those most vulnerable patient groups, but doesn't leave the practices feeling vulnerable to being just inundated with calls that they just can't cope with. I think most practices would say, you know, they continue to get high numbers of calls every day about access to services. So, and the flexible commissioning element of the contract is actually relatively small. There's a sort of ceiling on how much you can flex by. So it's up to this 10% figure. So we're trying to do it a little bit word of mouth. And we've been recently at a sort of multi-agency forum about access. I think it was asylum seekers we're looking at. I think Alice was at that meeting as well, looking at asylum seekers. We presented at that and said, this is what we're doing. So words going round, but you have to be honest and say that the practices are still nervous about that sort of floodgate thing, if you like. So we're having to try and tread carefully with that. I think what we'd like to do in the longer term, we think we've got quite good take up, 30 practices involved. We'd probably like to get, but if you look at that 30, so just to make that point there, 18 of them are in Oxfordshire, 8 in Buxton and only 4 in Berkshire West. So I think this thing will work best if we can go at sort of scale, and so it's early days yet. So there are some challenges around that.
Thank you.
Sorry, a question to Nitin, really. Nitesh, sorry. Is there a body representing the Bob dentists that we can communicate with? Because, I think the message coming from Hugh is, it helps if this is scaled across the larger region. but is there such a body as a Bob group of dentists?
There are several groups. So there's the local dental committees, and you'll have one for Berkshire, one for Oxfordshire, and one for Buckinghamshire. So they do represent their members. They and I guess I should say I have a dual role. So as well as being the local dental network chair on my NHS side, I also am the chair of the Buckinghamshire Local Dental Committee, which is quite unusual having these two roles. But dentists overall are always slightly nervous and apprehensive about doing things sometimes differently, and so sometimes it can take needing a few people to start it off, start the process, see how it's going, making sure it's run as they would like it to be run, and then they can pass the information across. So I think we're probably at that sort of phase at the moment. But it is, I mean, I'm one of the practices doing it in my area, and it is incredibly rewarding. It allows the type of patients who will struggle to get access, and it takes away the fear on behalf of the dental practice about taking on too many risks for them. So, for example, in some of the patients that we've seen, we've had both adults and children who've come in, and it's harder when it's children really to see this sort of thing, who come in who need 6, 7, 8, 10 fillings, 2 or 3 extractions. I've seen in our practice children as young as 10, 11, 12 who've not had all their adult teeth, and they've needed several adult teeth taking out. But with the flex commissioning scheme, it allows us to spend the adequate time with those patients and get them what we call dentally fit. So removing all the decay, removing all the any teeth that need to go, and it allows us to spend the time that we need to. But in terms of to answer your question, yes, there are those 3. There are dentists representing. There are groups representing dentists, and that's local dental committees. The local dental committees also are represented in the local dental network that I chair and Hugh's a part of. So they've helped influence the flex commission scheme that we have, and then they take them back to their committees to spread the word.
Thanks a lot, Nitesh. I think Alice wanted to contribute.
I did. Thank you. Thank you, Chair. Just to answer to the councillor's question, what had happened was when Hugh had shared with us about the Flexi Commission services, we shared that information to all the vulnerable groups that were on that list. So a lot of the people are aware of this service and have been told how to use that service. So that's been one of the ways that we have been sharing the information.
Thank you, Alice. Further questions, anyone? I've got some questions, Hugh. Obviously, I think Tony touched on this earlier with regards to dentistry practices leaving the NHS. Obviously, this is disappointing. I can see there's a mitigation plan in place, and that's helpful. I think Twyford and another dentistry practice is involved in helping with that. But my question really is a more broad-ranging question. Do you think everybody who's involved is doing enough to make sure that we lose as few dentists as possible? Is there anything anybody else can do to help with this situation?
That's a difficult question. I mean, I think locally, we are trying to do what we can within the confines of the contract that we have. So, we have a good understanding of what's allowed under the contract, and this is the flexible commissioning scheme, and we can sort of pull some levers in that respect. We're investing in referral services in terms of their sort of recovery of their waiting lists. We're looking at a sort of recommissioning program of primary care, which is, as we're hoping, is not going to require us to go through these very formal procurement processes, which will allow us to commission with local practices, which we hope will help boost their business in terms of having more NHS funding. So it will increase the ceiling, if you like, in terms of what they've got. But I suspect the big question is what's going to happen nationally. in terms of the contract, and the dentists have had concerns really about the sort of UDA type contract they've had for a number of years. The change that was made in end of 22 was really the first alteration of that contract in sort of 16 years. There's talk more of other changes coming along, but I think that's really where it could have the biggest impact, is something that can be sort of developed and agreed with the profession.
Thank you for that, Hugh. Moving on to, I think it's on page 14 of the pack I've got, which is getting back to normal after COVID, if I can call it that. And we can see the graph there. Obviously, there's been a considerable uptick in recent months. When do you think we will get back to the sort of 2019 level, or will we never get back to that level? And what's the cause of that? Is it just people really disengaging with care providers, with dentists, or what is it?
I think there's workforce is certainly an issue in terms of our ability to get back to where we were in 2019. It is variable across the South East. So if you look in the Frimley area, they're actually getting close now to 90% of contract delivery, which is we've never been at 100, but it's getting back towards that sort of 95% we used to be at. So Frimley's recovering quite well. Only lost one practice, and I suspect the workforce issues are less significant there. I think there are still issues about patients who've had their gaps in treatment, which means they've got increased treatment needs, needing more care, and also I think there's an issue about us all as a population getting older but retaining our teeth, and then actually needing more work done with the dentist as a result of that. So, and I think the other question we have to think about is the sort of goal, if you like, of getting back to where we were in 2019, that one we absolutely want to go for, or do we want to have something that creates a bit more flexibility in the way the service is designed through something like flexible commissioning, which just creates sort of more incentives in the system for the practices to bring in those more vulnerable patient groups. The way the sort of contract kind of works is it sort of incentivizes those regular attenders, those who will go back to the dentist at regular intervals, look after their oral health really well, and so we've always had sort of services that work alongside those to support patients who maybe have greater challenges getting into that system. Community dental service often provides that sort of support, but could we be doing something more through the high street dentist that actually really starts to support those patients with greater oral health need?
Next question is really on the contracts. Ever since I've been listening to the radio, I've heard dentists complaining about this contract. It looks like finally there seems to be a little bit of more flexibility in it. There's a quote saying, there's going to be a £23 minimum value for a service, which I know previously dentists had complained about, and this flexible component which you talk about. So I'm very keen to get an update on that at our next meeting in 6 months or whenever it is, to check progress on those areas, and as you've mentioned, also any progress in the national contract situation, because we want happy dentists delivering good service to our residents. That's not really a question, more of a statement. I don't know if you want to add anything to that.
Yeah, I mean, the £23 minimums, the £23 minimum is in, so that's been implemented now. There is one of these issues, is this UDA price is it's all based on a reference year back in 2004-05. There is divergence between the practices. And I don't think it was thought at the time that this would be in place for nearly 20 years now. So yeah, the review's long overdue. They have tried sort of prototype type arrangements as well, but yeah, I mean, yes, I mean, I agree with your statement.
Nitesh, are you there?
Yeah, sorry, I couldn't. I didn't hear. So I think I said some of this last time, but so I'm here in my NHS role, but my priority is having patients seen. And so I will say a few things which probably may not fit with the role I'm here as, but I think it's probably helpful for you. When the government or the NHS talk about them raising the minimum to £23, that's a complete red herring, because if you offer £23 a UDA to any dentist, they will turn you down. They've raised the minimal level from incredibly poor to just poor. So if you went around offering anyone £23 UDA, no one's going to take that up. But I wouldn't expect you to realise that. But I want you now to know. So that doesn't really help anyone. It's just something that the government have announced, which is pointless. When you ask Hugh what would he like to see going forward, and Hugh gave a very good answer about how do we focus on resources. I would like us to get back to 2019, and I'd like to get above that. Even 51% of the population, I think, is a poor figure for a Western country, a G7 country. I think it's appalling. So I don't want our resources just being allocated to certain parts of the public. I want them available for all. Although, I'm very mindful of the vulnerable, and it's very good, they need to be seen. There's lots of groups out there who don't fit into the vulnerable groups, but they really need services. And I'll give you some examples that come to my clinic over the years. I can think of that pensioner who comes in, who can't afford a denture, which is £300, because the pension doesn't cover it, but they won't fit in the vulnerable group. I think of the patient, and Hugh knows this, I've spoken in our own committees about this. I'll think about that two-parent family of two kids who are struggling to pay their bills, who can't afford the £70, who could just about afford the £70 for NHS treatment. No way can they afford £700 for private treatment. I don't want them discounted. They don't fit into any vulnerable groups that we identify. So I want them all to be seen. So I'm not happy with staying at the percentage of the population we're seeing. I want us 2019 and above. I would like the patient representatives to ask about the budgets. I would like them to ask about how much is spent on dentistry, what is allocated to dentistry, and what is not spent. And what is not spent, how can we spend it before it disappears somewhere else? Those are the sort of things I think it might be useful to ask. And for Hugh to then go back and say, I've been asked these sort of questions, because actually I think this area is very lucky to have Hugh in his role, but Hugh will have people he has to answer to, and people who will give him the confines of how he can work. And so if I was a member of the public, I would want to know about how much money spent on dentistry, how much money spent per person. And I think in one of the papers I saw £31. Think how much £31 of healthcare can really buy anyone. How much money is allocated to dentistry, but it's not spent on dentistry? And if it's not spent on dentistry, how can it be spent? I think if you ask those sort of questions, you might help. You might help some of the population.
Nitesh, really appreciate your very honest and forthright views. Thank you very much for that. Building upon that, and perhaps a little bit from personal experience, my best friend is a pensioner who's on a pension which is, I believe, about £600 a month, so about £7,000 a year. So he has all his household bills, and he doesn't receive any universal credit or benefits of any nature. So out of that 7,000, he has to pay, because a lot of money from his perspective for NHS treatment. So I think his last treatment was £85. Obviously, £85 in a month where he probably has less than £10 a month discretionary spend means that he's, in a sense, in a vulnerable group, but he's not officially in a vulnerable group. And if I may just make a comment here, this council has a fund for council tax where people can apply, whatever their circumstance, to get relief from council tax. So the people that don't neatly fit into a vulnerable group but are struggling financially can apply to us. So my question to Hugh would be, why doesn't dentistry have a vulnerable or outside of vulnerable fund so that dentists who see patients who really desperately need dentistry but do not fit into a vulnerable group and don't get the necessary funding, so that they could call upon that fund so that the person who's desperately in need could receive some treatment?
So, I mean, there are patients who are exempt from charges. But that's all laid down in statute in terms of who's charge exempt. So we don't have local powers in that respect. So I think that would be difficult for us to sort of intervene locally in that way. We just wouldn't have the legal authority. It would be illegal, if you like, in terms of, because we'd be going against the patient charge regulations. So, I mean, I think it's a good point being raised that we're saying that access for NHS dentistry, you know, in terms of the population increasing that, and in fact, picking up on Alicia's point, we are actually, in terms of the plan we're following next year, looking at additional investment into dental services. But Nilish's point is also an important one about any decisions made about dental services are in the context of others, in terms of the NHS, and where does it come in on the priority list. So yeah, I think that is a tough one when you then fall outside these patient charge exempt groups, and then you're probably just over that threshold, and then you're deemed not to be eligible. We don't really have local powers in that area.
Thanks for the answer, Alice.
So you're saying those pregnant women who have been given exemption, if they pass that 1 year, they're not entitled to have any.
That's right. That's the eligibility is for that period. Yeah.
But it's not their fault that this has happened, because they are struggling to get the services. There must be something that has got to be put in place because they're vulnerable.
I think some of those are being picked up through flexible commissioning. I think we're seeing some of these in these other categories that they are getting in that route. So, but again, what we're looking at with this sort of flexing of the contract is we're starting with the sort of groups we're looking at now, but can we get more practices? Can we look at other population groups that we might be able to get into the system to do that? There are sort of just practical complexities of doing this in terms of just how we, design the way it works with the practices, the arrangements we have to put in for monitoring it. There's the sort of national infrastructure around how dental contracts work, and they get paid at the moment. So we have to design something locally to do that. But that is something we're looking at, and we're looking also in some areas about whether we can look to sort of look at services that might be a combination of mobile and fixed, so we are trying to think laterally about how we might do that, but it has to be within the limits of the powers we have.
Thank you.
Question from Tony.
Yes, is it possible? We're seeing half the picture here in a way that some of these dental practitioners are going away and going to the private sector. Do we have any numbers for the number of patients who are seeing dentists privately, so that we have an idea of what percentage of the total population is being covered by dentistry, and therefore who is not?
I don't think we have precise figures, but as an estimate, it's about 50% go to the NHS, about 30% go privately only, and about 20% don't go at all. So they only go if they have a problem. I mean, they're very rough figures, but that's the sort of proportions. And there's probably a bit more private in an area like ours compared to others.
Thank you.
And right now, I'd like to just have a look at the budget, actually, which is page 15. So the report says in January, the number of commissioned units was as followed, and in June 23, the figures, I presume this is actual delivery, were as follows. Yeah. Is that my interpretation? Is that correct?
That's the commissioned activity. So yeah. The delivery is a little bit below that.
So the 182,513 is the number of units you proposed would be delivered in that period.
Yep.
And 172,237 is the number of actual units delivered in that period. Is that correct?
That difference is the impact of the loss of the Bean Oak surgery. So it's an adjustment downwards in terms of recurrent commissioning, but that activity is being commissioned temporarily from other practices. So if you like, the money stays in the system when we can use it somewhere else, and then we're looking to recommission that permanently from next April.
Yeah. So I think perhaps my interpretation of these two tables is a little bit incorrect. My assumption is that the first table is the budget and the second table is the actuals. Is that not the case?
They're both showing planned activity and planned spend.
Okay. So I would be always interested in the number of actual units delivered, because I think if we were to see the actuals, then we could get a feel for how much budget, if you like, has been consumed. My assumption with my questioning is that all of the budget will be consumed. And if that is the case, is that not the case? Nitesh?
So I just need to correct you. It's Nilesh, not Nitesh. But if you look at the next table on page 15, the one at the bottom, I think that will give you closer to what you're looking for. So when the last one, where it says delivery 22-23 actual, shows working 85.43%. So essentially 14.5% of that 5.1 million, is it, Hugh? Yeah. Hasn't been delivered.
Yeah.
Right. Okay. So, that's helpful. Thank you for that. So what happens to that residual 14.5% is the next question.
So the answer is it depends on the individual practices' delivery of their contracts. So in a normal year, they get paid on 1/12 basis against an assumed level of activity. And in a normal year, they have to deliver more than 96% of that activity to retain all that funding at the end of the year, which finishes on the 31st of March. In last year, in 22-23, because we're still recovering from the pandemic, that target was reduced to 90% they had to achieve to retain all their funding. So if practices achieve between the 90 or the 96 and the 100, they can carry that activity forward into the following financial year. And if they go over that 100%, to which they can go up to 110% now. They can get paid for additional activity. That was the change that came in at the end of 2022. If they drop below the threshold, that 90 or that 96, those monies are recovered from the practices up to that 100% level. So whatever they've fallen short by, there's a financial recovery. So just to give you an idea, the recovery this year in Bob is about £14 million in terms of that underperformance.
Thank you. That's
in a normal year, about 3.5.
Yeah, that's a very comprehensive answer. Thank you for that. Next point is on page 22, which is the graph showing Wokingham's position. So if I look at this graph, one of the things that we have in general in Wokingham is challenges around budgets, because on some measures, we are the healthiest borough in the country, first out of 149 equivalent authorities, I believe, on some measures. But actually on this measure here, which is for 5-year-olds going into I'm not sure exactly what it is, but it's 5-year-olds.
Year one.
Is it kind of major dentistry? Is that what we're talking about here?
Is that the bar graph?
Yeah, that's a bar graph.
Yeah. So that's experience of dental decay. So they're national surveys that are done at intervals. So this was the latest one in 2019. So yeah, Wokingham was somewhere in the mid-table here, wasn't it, on that one, I think?
Yeah, it was a sort of mid-table, which is a very disappointing result from my side. But looking at the worst cases, they're all quite close. So Slough, Reading, Wickham are very, very close to us, actually. So, however, when I look at other places, they seem to be zero. So, Woking, Surrey Heath, Tandridge, Runnymede, these kind of places. I wanted to understand. Oh, they didn't participate. Oh, okay. Sorry, I didn't understand the graph.
Yeah.
But I would like to understand how we get to a better position like Hastings. What measures are we taking to improve our graph position?
I mean, it's worth pointing out that Slough actually I think, is one of the worst areas in the country for oral health. It's in the 13 local authorities with the worst oral health in the country, and pre-pandemic, there was a sort of national program called Starting Well, which was designed to support practices to try to bring in children from an early age, sort of trying to get the under twos to attend the dentist at regular intervals. And we were just rolling that out to other areas, actually. This was a sort of local dental network led program that we had. That all sort of came to a halt really with the pandemic. We're now looking at how we can get this sort of thing reactivated. So there's an element of it being picked up in flexible commissioning where, for instance, looked after children involved and asylum seekers, things like that. So it's quite narrow at the moment, but part of the discussion we're having is, well, if we do what we're doing with the contracts, can we try and build in a sort of flexible commissioning, a looked after children type approach to it, because we do recognise that if we can be doing things early on, that will support improved oral health.
Thank you, Hugh. I think Beth has a question.
Yeah, thank you. It's Beth from Scrutiny. Can I ask a question? It's a very simple question. With the vulnerable patients, how are we getting the message across to them about all these services for them? They need 3 fillings or 10 fillings to fund things the same, and so
Yeah, thank you. I'd like to look at special needs children, because we have an awful lot of special needs children in our area and in other areas. And how are special needs children with special needs and disabilities accounted for in these figures?
So the aim would be, as far as possible, they should be able to attend high street practices. But if they're in a position where they are not able to, then it's the community dental service will pick up on their needs. So whilst the community dental service is kind of known for supporting people with learning disabilities, particularly in people with mental health issues, actually about 80% of their activities with children, and a lot of that is on an ongoing relationship with those children. So that the service then has arrangements to sort of monitor the oral health of the children and do things like fluoride varnishes, interventions to maintain their oral health, and also they provide the hospital extraction service for when the children need to have their teeth extracted. So, but just as an indicator of the issue here, I saw very interesting statistics a number of years ago for the Berkshire Community Dental Service, where I think it was something like 44% of their children being treated under GA were coming from, was it 4 postcodes, 2 in Reading, 2 in Slough? Really concentrated in terms of where those children are coming from. And that's where these starting well type projects are coming from, to try and get this early intervention, try and break that cycle.
This isn't really a follow-up question, a change of subject. We're all aware that the hospital service is losing GPs and other medical staff overseas because the wages are a lot higher, the living conditions are a lot higher. Is that the same with dentistry as well? Are we losing dentists to Australia and New Zealand and goodness only knows where, that pay more than we do?
In our local hospital service, because we work closely with them as well, I'm not hugely aware of that being an issue, but I suppose we tend to know the people who've kind of got the more established careers within the hospital, so there might be people in terms of coming and going in that respect. I don't know, Nilesh, are we hearing about lots of dentists going abroad?
No, I think the reality for dentistry is the NHS is losing them to the private sector.
Yeah.
So they're less likely to move abroad because they've got other opportunities in this country, but unfortunately not with the NHS.
Any further questions for Hugh, Nilesh? Thank you. Really appreciate your time, both of you. It's been very, very helpful. Certainly, Dr. Patel, thank you very much for giving us very, very, I don't know how to word this, very from the hip answers. We really appreciate the understanding that you bring, from the cold face of a practicing dentist. That's very important to us. And we look forward to seeing you again. Thank you very much. And I must say, Hugh, that reading your report was massive transformation in a positive way from the report I saw 2-3 years ago. There's lots of data in here. There's lots of information. You're really being transparent and helpful to us as a committee. Obviously, we're giving you lots of difficult questions, which is basically around money. We are all worried about the amount of money. We're all worried about the number of dentists delivering NHS dentistry, and we're worried about our residents. And hopefully those questions relate to those topics. But it's a really fantastic report, Hugh. Thank you very much. Really appreciate that. And look forward to seeing you again next time. Thank you very much, both of you.
Thank you very much. Thank you.
Thank you.
Bye-bye.
Bye.
I need to hand over to the lovely Wes.
Lovely, thank you very much. I will share my slides. Bear with me a second. So part of the intent today is also to show you a short video that we have in relation to our not sharing, Madeline. Sorry, I wasted your journey. Yes, so I'd also like to show you a video today. Part of that, the rationale for showing that video is it includes the views and experience of some of our service users in Wokingham. And I'm going to be talking about the Adult Social Care Specialist Accommodation Project. So in terms of where we started our specialist accommodation project, it was reflecting on our learning disability strategy and how we support people within the community to live a full and independent life. And what we knew is that the number of adults with a learning disability that we support in Wokingham was relatively high in terms of numbers. And we knew that that was likely to increase when we saw an increase in the population. And we also knew that there were a number of residents living in the borough in accommodation that we deemed to be unsuitable. And this first slide is quite important because that gives you an insight into what we mean by unsuitable in terms of the standard of accommodation there. So you can see an actual house that we're talking about here. And our strategic goal and our ambition was really to create that environment that maximised independence for people with learning disability. As we went through this journey, it was a long-standing programme. We expanded what we meant by specialist accommodation and included adults with mental health needs as well in terms of the project. What we were looking to do was reduce, for learning disability, reduce the number of residents who lived in more residential-based care, so like a care home for people with learning disability, and support them to live within the community with greater access to use of technology. And we're really striving to maximise the partnership that we have within the local area, within both our wholly owned companies, but also within the landlords as social housing landlords to maximise what we achieved there. So in terms of how we funded this project, Adult Social Care has a capital programme, and that was utilised to fund it, as well as Section 106 contributions, which formed of that. We had an NHS grant, which supported elements of the contract. But ultimately, that's the source of that accommodation. And I should have said, sorry, right at the beginning, when I'm talking about the accommodation projects, lots of different houses, lots of different types of accommodation that make this up. But we were able to utilise Section 106 and use our capital programme to fund additional accommodation within the open market. So we're able to utilise our capital programme to renovate, refurbish properties, as well as adapt purchases that or projects that came through the 106 contribution. In terms of the care itself, we worked with Optalis as our strategic partner to support us in developing the care options available in the accommodation, as well as specialist mental health provision as well. You can see the kind of pictures emerging on these slides now of different types of accommodation. So it was a locally driven project, and this was led by Adult Social Care, but really brought together all the relevant departments within the council and the wider partnership to really make this a success. And it was bringing those people together so that we really created that stability of tenancy for vulnerable people within the community to achieve the best possible outcome. So what we've now delivered what we call our phase one, and we've accommodated 36 people within the community in new adapted homes. Again, you can see a picture of one of them there. It's good quality care that we're providing on site, which enables people to be more independent as adults and achieve greater independence through the community and become part of that community in which they live with that secure tenancies. And we got happy families and that are really happy about where they're living now. The graph that you can see is the percentage of adults who live in their own home. we've seen a steady increase in that percentage. We want people to live in their own home independently, and we've seen that go up through the life of the project. So in terms of performance, now we're above where we are. Now, if technology works, I will turn my microphone off and play you a video, which, as I say, should show you a little bit of the experience of people living in accommodation.
I'm delighted to introduce this video on the Adult Social Care Accommodation Programme that is enabling people who are amongst the most vulnerable in our community to secure high quality supported living in the heart of the community.
Over the course of the last 18 months, I worked with our colleagues at Woking Borough Council's Adult Social Care Commissioning team to deliver 31 properties for supported living across the borough.
Butler House is a specialist accommodation for adults with mental health support needs, with 10 flats, and also has 2 emergency accommodation flats as well. Although there's background support provided and people have one-to-one support going into their flats, they still get the sense of independence. And because we're in the community, they also get to feel a part of the community.
I absolutely love living here. I think I'm lucky to have the flat. Big, it's new build. It's very cosy here. I'm a bit more at ease having the spaces to myself. I'm more independent now living here than I was beforehand.
They've helped me socially within groups and on my own, which is brilliant. I never got before. I felt like I was stuck in my room before, whereas here they encourage you to go out and about as much as you can. That's the kind of support that I've been looking for years. Makes me feel good that I can do things on my own as well as with support.
So here we have 2 bungalows, one with learning disabilities with 3 bedrooms, and next door we have 3 bedrooms with disability, physical disability. So it's equipped with hoists and kitchen surfaces that rise up and down. It's been lovely to see how the guys have changed. They really have. They've become so independent. Now they're helping cooking, cleaning, washing. So one of our residents with his DVDs, his films, it's a joy to work in it.
The staff are friendly here, and they accommodate your needs very well.
These people are in a special school and then they're sort of gone out, whereas the rest of us go out to work and we get that help. Where they don't, where Wokingham Council has stepped in.
It's like we were at school together and then we disappeared for 5 years, came together for HCPT and Lords, disappeared again, and 10 years later, thinking that I'd never see him again, we end up being put in the same house.
We used to always think, my parents, well, what are we going to do if anything happens to us? And now people in Wokingham area haven't got to worry about this anymore.
The area is relaxing round here.
They're not made to stand out any different from anybody else who's living in the area.
The beauty of us being owned by Wokingham Borough Council means that we are able to respond directly to borough needs.
So a piece of work was carried out between the property team and adult social care to assess the requirements and demands that adult social care have against the available property and assets that the council had that were vacant. Rice Green and Highwood Bungalow were chosen as being suitable properties.
We've got here 5 individual flats. When we did assess the individual, he had a very high needs in terms of managing his behavior and lack of independent skills. Here he was offered to move into 1-bedroom independent flat, and that gives him a lot of his own space. He can clean himself now with a little prompt from staff members. He actually can cook. The improvement has been extremely high. He improved his skills in terms of communication. The behavior concerns we had when he moved in has reduced to the point that we have no incidents in the past couple of months, and he's just living his life.
Highwood was a huge team effort. It involved working with Adult Social Care Commissioning team. It involved working with London Homes, the care providers and the occupational therapists. We increased it to 3 beds to meet the needs of 2 residents and a carer. In 2019, WBC declared a climate emergency. So at Highwood, we have put 41 solar PVs on the roof. And we've also introduced an air source heat pump. The air source heat pump provides hot water and heating for the building and should give us a 100% reduction on its carbon usage.
All this has been made possible by excellent working across the council and working with our external partners.
We are all working towards the common objective of providing high quality, good, decent housing for these people who need it most.
So hopefully you saw the impact that the specialist accommodation project has had on the ground in people's lives. And this has supported people who have both come from the accommodation I showed you at the beginning, the unsuitable accommodation, but also people transitioning into adulthood and moving into their first home. And we've been able to use this specialist accommodation project to really manage the demand within adult services. In terms of, sorry, I appreciate that I've come on to a different view. We're now moving towards that phase 2 of the project and how we can continue on this journey to support people who are transitioning into adulthood and address that level of need within the borough. And we're working very closely with our colleagues within housing and developers in the local area in different ways, which we can seek to drive change. And we've done a lot of work in terms of our evaluation as well. So we commissioned, well, we were successful in a grant for the LGA Housing Advisor Programme, and we were able to get a piece of work done around what do we need next for the project, because one of the most difficult aspect of this is matching people, and we've adapted in the way in which we respond within the local area. That hasn't moved on. Okay, so as I say, we've really helped people to gain that level of independence, and you can see people here doing lots of different activities, living, and you heard those two chaps who went to school together, went away together, came back together, and you can really, when you get down, you really feel that community vibe amongst people living within the community, and that's shown in the pictures. And I guess the bottom one, I'm the one wearing the silly suit with a waistcoat. We also won a Municipal Journal Award for best practice within this year. So we were able to win that award as well. So we know we're in the area of best practice there. Okay, so happy to take any questions.
Rebecca, please.
Firstly, this is excellent. I've worked with adults with learning disabilities, and I've seen adults that have grown up in homes and never left care homes and are unable to. So to see this is absolutely fantastic, seeing adults live independently. So I was wondering how you work with children's services as in identifying those young adults that are coming through to make sure that they can be independent, and we encourage that independent journey with adults as they become an adult. So, how are you working with children's services? And then I've got another question.
So we have a transition team that work with children that are transitioning from children's services to adults. They start engaging at 16 and working towards independence. They're obviously independence and supported accommodation. It's working with the individual around their needs and working with the social care team to make sure that we're making the right type of placement. But we do have a transition team that work across children's and adult services.
And my other question was, on a very practical level, this is a much more cost efficient way, and we have to look at the way of how budgets are managed of helping these people for the council. So kind of moving forward, you talked about Section 106 money. We've got a huge amount of development going on in the borough, and I'm sure it will continue. We all know that's fact. So with the Section 106 that's coming in from all new properties that are being built, are we, you looking forward with that about allocating new build properties within big SDLs or anything which could be used for these kind of facilities?
Yes, you're right. In terms of financially, it helps, particularly around registered provision. and moving away from registered provision. And our project is, in the short term, is looking at those additional ones that we have currently registered that we can deregister, and that will be a key aim in the short term. What this project has done is brought adult services and our development colleagues, our property colleagues, very close together, and we're regularly involved in the conversations around developer contribution within the local area and schemes which have been identified for delivery in future years. So yes, that's ongoing.
Caroline?
Good evening, thank you. I see you've got phase 2. Is there anything you've learned in phase 1 that you'll put in place in phase 2, or something you wouldn't do, or something you would improve on? Thank you.
Yes, so traditionally we've looked at accommodation as a house and how you can get 2 individuals to live in a house together. So we know we have high needs. I'm sure people will recognise often people don't like living together, and because we don't like living with certain people, and it's exactly the same scenario. What we've learned from the LGA Housing Advisor Programme is that we should be looking at more clusters of flats, and that's similar to what you saw in the video with the flyover with the flats. That's something that we should be working towards in terms of best practice, rather than having a house environment where that social dynamic comes in play, because people still want to live together, but being able to utilise property in the right way to maximise it is through more cluster flats, it's called.
That's very interesting, isn't it? Thanks. Is there anything else? Sorry.
I think going back to the point around working with the developers, I think what we've managed to move towards is having that constant ongoing conversation, and it's good to see that happening. But in terms of learning, it's having that pipeline ready so we have that flow, because the need doesn't go away. Children will always transition from SEND into adult services, so it's being able to maintain that pipeline going forward, and that's through the conversations around developer contributions.
Thank you.
Beth?
Thank you. Huge congratulations on this programme. As Rebecca said, it's a real big step for the council. Highwood Bungalow sits in my ward, and I half expected some comments, remarks, complaints from local residents to it, because it is surrounded by houses, and there has been absolutely nothing but praise. And I have to say that is really good. The residents haven't been tolerant. They're certainly not tolerant, but they're very helpful, and they keep a watchful eye on what's going on. So if there's any trouble, they would very quickly alert us. When it's all peaceful, it's just like your neighbour. And I think that's a really good thing for residents to be integrated in that way, which is very informal and very low key, but nevertheless, they've got a parental eye on what's going on. And I think that's gratefully received.
That's fantastic news. Obviously, Wokingham is part of the Social Care Futures movement, and part of that is about supporting service users within the community and being part of, or the heart of, community life. So that's really fantastic to hear.
Tony.
Yes, Wes, just something I'm curious about from what you're saying. You think that it's better to have the people in individual flats. If they were in those individual flats, would they have a communal area that they could socialise in?
I think it's a mix of accommodation. So the cluster flats is a model that we think works best. So that doesn't mean that we would 100% walk away from houses, because it's down to the individual need of the individual. And it may be that 2 people are living in a house together at the moment, and they can live together in an alternative house. So just to be clear, we're not saying we're not doing houses anymore, but in terms of the learning, the cluster flat model works better for individuals. But yes, there will be elements of community living as well within that accommodation.
Thanks.
If there's no further questions, I'd like to thank Wes for a great presentation. Not obviously what looks like really outstanding accommodation, and we are, as a committee, really pleased to see this, and it looks absolutely outstanding. Thank you so much.
Thank you.
I think the next item is also yours. I think it's home care.
I apologise, these slides aren't as exciting and I don't have a video, but I'm moving on from that. So, so talking about home care or domiciliary care. So I understand that at the last meeting there was a question in relation to home care. So the purpose of this presentation is to provide an overview in terms of home care within the local area, and obviously happy to come back if there's more specific questions in relation to home care. So home care or domiciliary care is about providing regulated activity of personal care within someone's home. So this is someone living at home, and we are providing personal care in that person's home. So the need that that individual will get will vary greatly based upon their needs that they have. Typically, but not always, provided to older people over 65, and the amount of time that a person will be visited varies again based on the individual's needs. So when we say support personal care, it's a washing, bathing, cleaning, etc. Not the lawn mowing of the garden. This is related specifically to personal care, and that will be regulated by the Care Quality Commission. So we have a duty in Wokingham to maintain the market and have a sufficient market in the local area which offers choice and it's safe and affordable care for local people. So the market itself will be a mix of both local authority commissioned home care, as well as people who are paying for their own home care, or private people who will commission their own care, which is the case in Wokingham. So in terms of what we have in the local area, so we track capacity through the NHS capacity tracker, and we have 50 providers in the local area that we know about. And I would say that the dynamics of the local market is that we also will often or use providers that are registered out of borough but serve within the local area, and vice versa. So you may have a provider who's based in Wokingham, but their business may be predominantly in Windsor and Maidenhead, etc. So this is the registered, where they are registered. And those providers are delivering 2,100 to 2,100 people, and they have a large staff base of over 1,800. So we commission, so this is adult services, over 7,000 hours a week to 507 WBC funded clients, around circa £7 million per annum. We use a care and support framework, which is a mechanism by which we commission out those individual cares. It's a framework of providers based on a number of lots, and we award the care through that framework to local providers. So there is a check-based system to get on the framework. Once they're on the framework, we can commission directly from there. So it's a 5-year arrangement. Initial 3 years until October 23, and then there's those further 2 years, and we are currently looking at that framework now about next steps. Self-funders, so this is people who pay for their own care in the local area. Wokingham obviously an affluent borough, and there is a large proportion of people who pay for their own care, and in the borough, in the southeast, that tends to be about 44%. We've recently done a piece of work around self-funders, and we believe there to be 619 self-funders in Wokingham. Obviously, that is based on nationally provided statistics, and we've worked out a level of tolerance to work that out. Obviously, the self-funder doesn't have to tell the local authority that they're paying for their own care, and that's done independently. Care and support framework approved in November. As I said, it has geographical basis to it, 15 providers on there, but we do commission off framework if we need to. The rates that we pay, £21 to £22 per hour for care, and that will be based on the geographical area, level of need, etc. But obviously we're committed to safety and quality within the market, and we really look at quality aspects and monitoring that contract. And as we said earlier, Tony, we try and minimise those 15-minute calls, those short level of calls within the local area. So in terms of how we ensure quality, as I said, have to join a framework. There's certain quality standards that a provider must meet in order to join that framework, and we check financial checks. We do health and safety checks, safeguarding, and we look at the CQC rating. So in terms of your CQC rating, and then we have a care quality team, which looks at quality related practice areas in each provider, and we manage those contracts on a regular basis as well. So in terms of how fertile the market is within Wokingham, over the last 24 months, we've had very few providers collapse, fold, fail. So we've had 3 in the last 24 months, and they are for a variety of reasons in terms of their provision. But we will continue to provide that further assurance on existing fees as we go through. So we look at our fees each year, and we make sure that we are setting our fees based on the funding envelope available, but also we benchmark in terms of rates and how much we're paying and work forward on that. So in terms of our home care market, it's not just about money and making placements. We support the wider sector as well, and we do work together in terms of supporting the sector around home care. So we work to signpost them against additional external support. We do centralised recruitment campaigns. So you may remember seeing over Christmas, there were little adverts on petrol pumps in the local area about a Wokingham run recruitment campaign for care staff. We have a workforce development strategy, again, how we support the sector to have enough workforce within the local area, and we have regular provider forums where we bring people together, talk about those strategic challenges that we have, but also how they can work together to support the local community. And I'm happy to take questions.
Questions, anyone? Tony?
Yeah, I was going to ask about the level of the workforce that I imagine, I read anecdotally, that there's a shortage of care workers, and is that something that we've experienced, that there aren't enough, and it's problematic recruiting them?
Recruitment across the whole sector is a significant issue in terms of rates of pay and the funding that's available. And so that it is a struggle locally as well as nationally. We don't struggle to find care, but in terms of that fair rate of pay, we obviously have that ambition to pay a fair rate of care within the local area. But yes, it is a challenge. Yes.
Caroline?
Good evening. Thank you again. Do we get many complaints, and do they come from the residents' family, or do you hear from the companies themselves, and how do we deal with them? Because I understand there can be. I watch a lot of TV.
We do get complaints in relation to, we don't get everything right all the time. So we will obviously get complaints from individuals, and we obviously look at those through the complaint procedure. And we do work closely with our providers. But obviously, there is recruitment struggles, and providers will seek to find a level of funding that they feel sufficient. So in terms of the annual uplift process, we have an appeals process in terms of money related complaints. And if there are complaints specific during the period, we also follow the complaints procedures. Not high volumes of complaints we receive, I would say.
Thank you.
Bill?
Hi, Wes. Having had some personal experience, not as a receiver of care, but as an organiser, I recognise that the recent inflationary pressures have caused people's savings to disappear more quickly, which therefore brings them more into the position where they will be funded, whether partially or fully, by the local authority. At the same time, you've got the inflationary pressure for the providers, which I dare say you haven't been able to match their expectations with regards to any rise in the rate of funding that you're able to provide. Are we in a position at the moment where we're able to fully fund all of the packages that are required by our residents, or are we having to rationalise some of that in order to make the budget spread?
So in terms of impacts of inflation, just to take that bit, so inflation is impacts on the sector, but also national living wage has a large impact on the sector. Given the rates that we pay and pays of the individual, they're closely aligned in terms of national living wage. So any increase in national living wage has an impact on rates as well. So it's a double whammy. It's inflation plus national living wage. So in terms of the rates we pay, last year we provided a 7% uplift for the sector as a whole. Obviously that varies between different types of sector. And that was the highest that we've paid in a long time in terms of that increase. And it benchmarked again, both against what our neighbours were paying, but also the LGA's advice in terms of uplift. Again, we don't have a problem commissioning care in the local area for home care at the rate on the framework. So we never struggle to find provision. And so therefore we don't need to rationalise. But saying that, obviously people's levels of needs change over time, and to manage our demand and our budget, we will look at those packages over time and complete those annual reviews, and then look at our commissioning arrangements thereafter. But to answer your question, no, we don't struggle. We don't have to cut it thinly to meet within our budget. It's managed within our budget.
So that's great. So, and good to hear. Thank you for that. But what I wonder is, what does the plan look like looking 2 years ahead? Because clearly one thing is rising, and therefore the available per person budget is potentially squeezed because of the difference between inflation and uplift that you've been able to achieve. Have you got a plan, even if it's only 2 or 3 years ahead, bearing in mind the relative limits of how long you will pay for someone, generally because of their age when they enter care, is controlled? But have you been able to model that so that that looks safe, or do things get closer to the margin as time goes on?
I think I can go back to it. The market is very volatile in terms of national living wage, and we believe that in the next year there will be sufficient budget to meet the demand in terms of the cost. And I think what we need to do in terms of our planning process is to look at our care and support framework again to ensure we have the best mechanism from a procurement aspect, so that we are procuring at the right price for the local area.
Any further questions? Just a quick question from my side. I just wanted to go over the topic of providers when they cease trading in just a little more detail, because I wanted to understand, if a provider ceases trading for whatever reason, who would you expect to take up the slack? And would that hit WBC directly, or Opthalis, or another provider? And what sort of mix would that be?
So should a provider fail, it's down to the host local authority to support them in terms of that transition. So if it was a local authority, a provider that failed within Wokingham, the local authority has a duty to support those individuals in the best possible way. Now, obviously, if there are local authority funded individuals, we would also have a responsibility to find alternative care for them. Optalis, as our strategic partner, is well placed to support us in the best possible way, generally speaking, for provider failure. Supported living, well placed to support us in terms of supported living. Specific to home care, because we have quite a fertile market, we would be working with alternative providers on our framework about finding alternative care arrangements for those individuals, and it'll be working with that group of providers to make sure that we can find alternative care. But it would be our duty to ensure that we support that provider through its failure.
Looking at the description you gave, and I would call it the service design. The service design to minimise 15-minute calls. The service design to include a quality team to assess the services being delivered. I think both these aspects I find very, very encouraging, because we see nightmare scenarios on the TV where care providers have to travel between different customers, and they have 10 or 15 minutes with a customer, and they're just constantly clock watching and trying to get out of the door before I would say the person being cared for is really settled and happy. So these aspects of the service that you talk about are very positive. I know this is probably the first time that we've received the report on home care, so I appreciate this is perhaps a little rushed, but obviously I think it's a topic, and building on what Phil was saying, we understand inflationary pressures. We also understand we have an aging population with more complex needs, with more complex care requirements. Therefore, and I would support Phil in his line of questioning, that we would need to keep a close eye on what we're expecting in the next years. Therefore, my request is a hard one for you. But what I think this committee would look for is more detailed information in terms of budgets, plans, actuals, what's being delivered by different providers, Opthalis, etc., etc. So this is not a question for you now. It's a request for when we come back to this, rather than having just the overview of the service, which we really appreciate, but we will want to dig into some numerical data, just like we've done with the dentists. 3 years ago, the dentists provided almost no numerical data. Now they provide a lot of numerical data, and we can start to understand really, what the budget is, what's being spent, how many units are being delivered, and these kinds of things. And numbers count. Obviously, I love the aspects you've talked about, things like quality and trying to have high objectives, but also numbers count. So I would be very interested in seeing a lot more numbers next time you present, if that's okay.
Yes, happy to provide that. We do on an annual basis. We have a market position statement, which is a 100-odd page report around the position of the market, which obviously we can provide in the short term if colleagues would like to see that, as well as a cost of care exercise, which we have to produce on an annual basis. So we have lots of data, and I'm more than happy to come back.
That's the right answer. That's perfect. Thank you very much. I think we would probably want a combination of those two reports, but also the probably just key aspects. I don't think this committee really wants to go down into hundreds of pages of reports, but rather, the really the items that really stand out to the team and to you, we would like to see next time. But thank you very much for that.
Thank you.
Alice, are you there?
I haven't gone anywhere.
Great, good to see you again, Alice. Thanks for joining. This is your time to give us a brief update. Thank you.
Okay. Have you all seen the report that we have sent in, the documents? So or would you like me to share?
We've seen the report. I think if you just give us your interpretation, that would be fantastic.
That'd be good. So the whole idea is HealthWatch is the same. You know, we get feedback from the public about the experience of health and social care. The reason why we wanted to bring you this report is to look at our priorities from this year till the 31st of March 2020. One of the things that we will be published, actually it has been published on our website, is the findings and recommendations of the enter and view of Wokingham Medical Centre, which we conducted in February and March of this year. But I know I am informed that you would like us to share the report in the future, and we are happy to do that. The second one is the priority that we would like to look at is about GP access. So just to share with the committee that in April last year, this year actually, we asked the public about what are the 3 health and social care priorities they would like us to look at. And GP access was one of the things that came up as a high priority. So we are in the process of conducting a focus group in Wokingham Borough, asking the community about the experience of booking an appointment with the GP. What are the challenges? Equally, we are hoping to also share with them the new way of working, because one of the things that we have found is a lot of people are not aware that the system has changed. So we will be going around. So there are 5 sites that's been allocated for us to hold a focus group. Equally, we will also be going to vulnerable groups and also asking them their experience as well. So that's going to be starting soon. So which is, I would say in Wokingham would be starting but now actually from September right up to November. We are hoping to bring the report to the committee and to the Health and Wellbeing Board by March. This is a very big project which has been actually signed off and with the cooperation of the Berkshire West Primary Care Network Alliance, as well as the Integrated Care Board, because we have shared with them saying that the public is very confused. They seem to think that they don't understand why they cannot see their named GP. So we are hoping to increase that awareness of the new way of working. And the second one that you've alluded to today was about dentistry. Dentistry has been one of the topics that we are still looking at, but in Wokingham, we will be asking those people with learning disability and pregnant women, what are their experience? Because we have had data sharing or feedback that has said that they are still struggling. And I've been in conversation with Hugh a lot to try and make this better, but we need to find out a little bit more from this cohort, what are the experience. Then last year, we presented to you all a maternal mental health report that was published by HealthWatch England, whereby 1 in 4 women were not getting the mental health check in surgeries at 6 weeks postnatal care, during their 6 weeks postnatal check. So what we are planning to increase that experience of women, that asking GPs to look at that service again, because the concern is because the Embrace report has showed that 18% of these women, of women who die of suicide, are during the first year of childbirth. So we will still be doing that. We also will be supporting the all-age transformation of continuing healthcare program, whereby we'll be doing a small exploration, a scale exploration of experience of those people who have not, who've had their applications turned down. So we'll be doing that, and this is what we'll be doing with Healthwatch Reading, Wokingham, and West Berkshire, along with Healthwatch Oxfordshire and also Buckinghamshire. Then the other thing that we have been aware of is also that our cohorts in Wokingham, the ethnically diverse communities have increased, and they've been struggling with accessible information standards. So we'll be asking services about what are the services available for those which language is not their English is not their first language. Equally, also what services are available for those who are deaf as well. So so those are the things that we are planning to as a priority, and we also have a watch list. However, our priorities sort of will change from the watch list. So the items in the watch list will go up as a priority if we get feedback. So one of them that has come up to the priority list is the asylum seekers experience, because we've heard that a lot of them, their accommodation, what has been happening is their rooms, they're having to share rooms. So there are like 2-3 beds in one room. So there's overcrowding itself. So we're just wanting to find out what is going on there as well. And also when they get their status, they are having to be leaving their accommodation within 7 days. So those are things that have come to our attention. And also the other thing that has also come up to our attention is about cost of living, and whereby people have been struggling about going to appointments because of transport expenses, and also the same with prescription. So I mean, the thing is, so these things change, and we are still trying to give the best that to ensure that the services are given to the public the best that it can be. We are aware that workforce is a challenge, and but we are trying to help as much as we can so that the public is aware of all the information that is needed. Thank you.
Thank you very much, Alice. Do we have any questions? Beth?
Yeah, Alice, sorry, it's not on what you've just said or what I've read about, but I've heard that some doctors' practices in the borough are not providing COVID booster injections.
Okay.
Is that right?
Yes, there are some primary care networks are not doing them, but what tends to happen is if they book within the national booking service, they will know they will get a service, and we are going. The information is going to come out soon of where can be provided.
So is that you call 119? Is it 119?
Yeah, 119.
Any further questions? Thank you very much, Alice. Really appreciate the update. Obviously, really looking forward to the next encounter when we see your report on Woking Medical Centre. But thank you very much for today. Thank you.
Can I just say, the councillor, Chair, can I say thank you for the support that you gave us with the Woos Hill Medical Centre. They have been really support. Happy with all the support that you have given. Equally, also they're engaging with us even more, so which has been really positive. Thank Thank you very much. So
you're very, very welcome, Alice. It's lovely to see you. Thank you very much for your time.
Bye-bye, Gabriel.
Yeah, it's a great smile.
Thank you. Bye, everyone.
I'm afraid it's Wesley again with the KPIs this time.
Thank you. So the report itself highlights some of the key performance indicators, as well as the top wins for adult social care in the last quarter, which, as I mentioned earlier, references the... Yep, sure. Have you got it there? It's in the pack.
I'd like to see it on the screen.
Okay.
That's really annoying.
Are you okay to bring up Madeleine?
Sorry, we had one meeting, not this committee, but another committee, where there were two sets of minutes produced with different page numbers. So every time there was a page, it was for those people with this version, it's that page. For those people with another version, it's the other page. So I'd rather see it presented than we can see it.
My apologies. So if you go up to the top, Madeleine, just to cover the... There we go. Yes, there we go.
Obviously, it's being recorded, and if anybody wants to see the recording, they wouldn't be able to see the minutes either.
Understood. So nomination for 3 MJ Awards by Adult Services this year, and as we mentioned, we won 1 for Best Social Housing Initiative in Adult Services, and that was for the presentation we discussed earlier. The other top win for Adult Services is we completed on the purchase of the Berkshire Care Home yesterday. And that's good news in terms of our management of demand going forward. So the report itself highlights the key indicators within adult services that are rated RAG. And would you like me to focus on the...
No, Rebecca's got a question on that point.
Sorry, Adrian, I just wanted to say, you've gone to great detail producing the report. We all should have read it. I don't want you to have to read through it all again for us. We've all read it, is what I'm trying to say, Adrian.
Sorry, that was not the intention, you to read the whole report. Just, for the people who see it online later, if they can't see any content, it will be a bit tricky for them.
So by exception, is there any points you would like me to look at in relation to the report?
What I found worrying was my life expectancy has gone down. I just wonder if it's not me personally, hopefully, but is there a trend that we need to be worried about, or is it just a glitch that... No idea. I just found it worrying.
Thank you for your question. Can I hand over to Ingrid?
Evening, everyone. Oh, not sure if you can hear me. Sorry, I have my headphones on. Evening, everyone. I'm Ingrid, Director of Public Health. So our life expectancy has moved slightly, but nothing to worry about. Not out of step with anywhere else. And actually a lot of focus, I don't need to worry, and actually a lot of our focus has moved not away from life expectancy. That's obviously a key measure still, but we are looking to look at disease-free or quality of life at the same time as life expectancy. So understanding that people live with a decreased quality of life at the end of that life expectancy, and really trying to focus on that bit and increase their quality of life, whilst trying to maintain as long as possible. We all recognise that we think nationally that life expectancy is kind of at its peak, as it were, and we're not looking for that to be increased further. We're looking for a greater quality in those last years.
Thank you.
Have you got any points you want to bring out from the report? Sorry.
I guess the two main points would be in relation to AS1 and assessments allocated within the 28-day period. We believe that performance has improved for the month of August, and that we have just completed in the last few months a redesign of the pathway and how we allocate through that process with greater specialism focused around the teams that will be allocated the assessment process. So it is our expectation that the indicator will improve in the next quarters. And the second one, which is red, is in relation to AS4, which shows that performance, although has reduced, we're still performing well compared to other local authorities in the area, and reflects performance nationally and in a trend of increased volume and complexity.
Phil?
Yeah, just quickly related to that, I presume, as you're saying, that you're catching up with the number of assessments. Does that mean that it's likely that AS4 will remain high as a result of the fact that there are more assessments going on, which seem to be at a more complex level?
Yes, so the increase in referrals is high. We believe that through the redesign of the pathway, moving away from more of a generalist approach to having teams around learning disability and early help, we'll be able to signpost people to more appropriate teams so that referrals can be addressed quicker. But they do remain high, but we believe they will come down with the redesign of the service.
Sorry, when you say a redesign of the process, is it a redesign or is it a tweak?
It's a redesign. So we're moving away from generalist to more specialist teams, learning disability team, rather than having a generalist team. So a person with a learning disability can be referred to the right person through that assessment process.
Okay, that's really helpful. Thank you. Have you got any further salient points or any further questions? Sorry? Please, Rebecca.
It was again about the social workers. I mean, if I'm honest, I haven't been to any. Previously, I was on children's overview and scrutiny, and this is always a red about timely referrals within social work. So we know there are obvious issues that we all know about. We've seen it in children's services, again here. So is it the same problems? You know, are you short-staffed with social workers? What is causing these delays, and how do you manage it? Because it just doesn't seem to be anything that is improving hugely, you know, across the board.
So in terms of the 28-day period and people having to wait, we as people are approaching that 28-day period, we're risk assessing them, or assessing the risk associated with the individual. So there's an element of contact, and if risk is identified through a risk matrix, then people are signposted appropriately. In terms of the pressure on adult social care, yes, social work recruitment and retention, like all areas, is an issue. We have a workforce strategy related to social workers in Wokingham, and we are working towards that workforce strategy to create. So recruitment retention is an issue, as well as demand and complexity within the system.
I think what you're saying is it due to recruitment that we don't have enough social workers that you're struggling, or is it a bit of process? Or I'm just trying to understand, because you know, I've only been a counsellor 2 years, but I've seen this each. I've been longer actually. Yeah. But anyway, no, it just seems to be a recurring issue across all sectors.
At the risk of providing misinformation, may I get an operational colleague to respond to that question directly?
Any further questions, Caroline?
Just a quick one on AS10, the percentage of adults with obesity. Is that the same as the national trend?
you able to cover that one?
Yeah, of course. That is a similar to a national trend. It's also a post-COVID trend. So there was a lack of physical activity generally across COVID, and we're seeing the effect of that now. We are working hard in public health and with sports and leisure colleagues to think about how we deal with that in a more strategic way. So there have been there's lots of things available to our communities, but they are not well joined up, and potentially is one of the answers. But also we need to think strategically and look at our evidence base around what we're doing for people who are overweight and obese, and develop an offer that's broader than what has previously or what was on offer pre-COVID. So we are working on that, and I'm very happy to bring that back when it's available to talk about. It's more of a physical activity focus rather than a overweight obesity focus, but very happy to come and bring that here when it's available.
Thank you. Keeping well hidden.
Any further questions? We're nearly at 9 o'clock. I think that's it, Wes. Thank you very, very much for your time. Really appreciate it. I hope your foot gets better soon. Also, thank you, Ingrid, for supporting the answers on that. The last item on the agenda is the forward programme. Do you want to talk about this, Madeline, as I'm always make a mess of this?
Sorry, I'm not going to go into too much detail. Just to say, at the last meeting, members noted that we had a lot of unscheduled items on the forward programme and asked officers to try and put them together in some sort of plan and then email it round. So what you see in the agenda is what obviously we put together and sent round for your comments. But just if you had any further changes you'd like to make or anything you'd like to add or take off.
In terms of the forward programme, I think there's a couple of things I would like to add. One is home care to be scheduled in alignment with the annual reports that Wes was talking about. So this, I have no idea what time frame that is in the year, but whatever is most suitable. It doesn't have to be the next or whenever. It's a sensible date in the future for home care with drill down into really the numbers. That would be really helpful. Alice already mentioned something, which is I've been reaching out to the local Woos Hill surgery and got in contact with their PPG, and we've had various meetings, including Alice. So Woos Hill and the PPG are well aware now that Health Watch exists because they didn't know Health Watch existed. So they understand what Health Watch is and what it does for them. They have lots of questions for us and lots of questions for ICB. But really, the key thing for me, key outcome from that meeting was some very pointed questions from the PPG to Bob ICB concerning, show me the money. What is the budget? What's the budget going to be next year? Are we going to get more GP services in Woking Borough or not? And so the answer provided by Bob ICB at that meeting with Woos Hill Surgery was that we need to develop a business case. So I requested Madeline set up a meeting with myself and Ingrid. Anybody else who wishes to join that meeting is welcome. But, that meeting's agenda will be to start to think about how we produce a business case saying that Woking needs another GP service. But so we're right at the start of the journey with this idea. So there's nothing on paper, nothing discussed yet. I haven't had this is the first thing that Ingrid knows about this. It's the first thing Madeline knows about this. So it's brand new topic that arose in the end of August. And either Madeline or Ingrid or myself have been on vacation. So we're all back from vacation. We just need to have a chat and see what makes sense for creating a business case. You should.
Can I link that, please, to the currently unscheduled topics of GP access and communicating different ways of working with the public, and maybe split them up so that GP access, including that, and then communicating different ways of working with the public are 2 items, and that we schedule them in separately?
I think that's a very sensible suggestion, Beth.
Yeah, can I just ask on that? Are we still in a situation that we don't have GP coverage in the new Arborfield sort of development area?
That I asked that question specifically and said, you know, we built some huge developments in Barkham and Arborfield, and as well as not having the necessary commercial premises there is also not a GP service there. But I see that David is raising his hand. Maybe, David, you'd like to comment?
It wasn't actually about that, sorry. It was about Beth's point that Health Watch are doing something about GPs working with the public and how GP surgeries are now very different. And you might well not see the GP, but you see the appropriate person who will, if they're not the appropriate person, will funnel you on to the appropriate person. So that's something that Health Watch are doing, and are doing certainly around the borough quite a bit. So that's something, and you could ask them to do that for you as well. With the Arborfield, I am not sure at the moment. That's something which I have asked and haven't had a reply from as well. So I think that's something we need to follow up. And whether you want to follow that or whether you want me to, I'm quite happy to if you'd like me to.
I would really appreciate it if you followed it up, and I will follow it up. But at that meeting where the ICB was represented, I asked the question twice. If Councillor Margetts was at this meeting, Councillor Margetts would say, where on earth is the GP provision for Arborfield and Barkham? And I really didn't get a good answer. At the end of that meeting, it was generically, there needs to be a business case before the Bob ICB will do anything. So this is why I want to start talking to Madeline and Ingrid about how we start creating a business case so that we have better provision of GP services in the borough. But again, reiterating Rebecca Margetts, I think there is a big black hole in GP provision in Arborfield and Barkham. I think that's it. Has anybody got any further?
Yeah, well, it's the only unmentioned, as far as I've been able to determine, subject on the forward plan is maternity mental health or perinatal mental health. Now, I know that there is some concern. I just went and checked online because I couldn't remember if it was 70% or 90%. And there was a concern about the number of midwives who actually have had any training to help deal with their patients who are experiencing that. And it's actually very high. The experience of mental health problems for someone in the perinatal period is actually higher than it is in the standard population. So perhaps if we could put it on the very next one after March, because as it's something which has been highlighted in this year by the Royal College of Midwives, as well as by the local talking therapy service and what they deliver, perhaps something which links how those two things are working together, and a report on what's happening from the midwives would be really very helpful.
Thanks a lot for that, Phil. Anything else from anyone? Meeting is closed. Thank you very much to all the presenters and everybody online. I wish everybody a good evening. Thanks a lot. Bye-bye.